This week on the BackTable podcast.
I personally believe if somebody has a true disruption, a PFUD injury, pelvic fracture, urethral disruption, distraction injury, I think a primary SP tube is always the way to go. I think if you can get a catheter across it, I think it does help. I think it can help with realigning the urethra and bringing two ends a little bit closer together to heal. I think you still, in my experience, 100% of the time, you end up with a scar. Even if it's pre-aligned, if it's realigned over a catheter and it heals over scaffolding, I've never seen one of those heal and not stricture down. So people who say, well, no, skip the SP tube. It's more cumbersome. It makes our orthopedic colleagues angry because they don't want to have an SP tube in the setting of their pelvic hardware. I say, well, all you're doing is you're like adding in a whole nother step to the future final repair.
Hello, everyone. Welcome to the BackTable podcast. My name is Arthi Hannallah. I am a pediatric urologist, and I'm here with my co-host, Dr. Niccolo Passoni. We are here, and we have the honor of interviewing and discussing some phenomenal case scenarios with one of our favorite trauma urologists. Dr. Travis Pagliara is a GURS-trained trauma reconstructive urologist at Hennepin County Hospital in Minneapolis, Minnesota. He did his medical school training at the University of Tennessee Health Sciences Center in Memphis, Tennessee, followed by residency in Minneapolis at the University of Minnesota. And he did his fellowship where it all began for the three of us at UT Southwestern Medical Center in Dallas, Texas, where we had the honor of being Dr. Pagliara's residents. Thank you so much for joining us today, Travis.
Thank you guys so much for having me. I couldn't be happier to see your two faces 9 years later. And you know, we're all in our adult jobs now and working, and I love that you guys both followed your passions and went into peds, and here I am still doing trauma and reconstruction. So I'm so excited and honored that you guys called and asked me to do this.
Well, thank you for joining us. Tonight's episode, it's going to be focusing on the nuances of pediatric genital urinary traumas. As the goal is not to go through the guidelines, those are readily accessible for everybody on the AUA website, but we want to discuss particular scenarios, especially because for us pediatric urologists that practice in pediatric hospitals, oftentimes we get a lot of kids transferred from outside facilities, and usually this kid get first evaluated in local hospitals or adult hospitals before being transferred. So we're trying to get an approach system-based, cover major or systems, renal, bladder and urethral, and then genital, and then go through little cases that can highlight the nuances and sometimes difficult scenarios. So without further ado, we're going to start by talking about kidney trauma. And oftentimes when I'm on call, we get called by the trauma service about, for example, classic example here in Texas, 9-year-old child that was outside on his ATV, rollover accident, gets evaluated, goes to a local hospital in the middle of Texas, get a CT scan with contrast, no delayed phases, shows grade 3 laceration, but we can't rule out a urinary leak, so we can't call it a grade 4. And now all of a sudden the child is here 24 hours in the trauma service, and we get called for urology. Oftentimes we get the calls like, do you think there's a urine leak? And the resident's first question is, do we need to rescan? So how would you approach that scenario?
Good question. And I do remember scenarios like that all the time. Texas has covered such a broad swath of land that, yeah, you got transfers from hours and hours away. I think what's interesting about this is the two things, like the corollary to the adult world is actually, you know, you have to kind of think of it, and I know we don't like this, as saying they're just little humans. But there are ways where you can say like, okay, if we do this in adults, does it apply to the kids? And the only time that it really doesn't is when you're taking a history. That's when I think it's really important. So if this kid comes in and they had evidence of blood in their urine that wasn't checked at the outside hospital, you could say, well, let's check that first, right? Because you're dealing with an outside scan, maybe not a trauma experienced radiologist, and now they're at your hospital setting. And rather than just immediately scanning the kid, if they look stable, you could say, well, let's check a urine. Hey, little kid, pee in the cup. Least invasive thing you could do, right? Find out if they have any hematuria. And if they do, you might say, well, maybe we can scan them now. Trauma centers also often have a pretty strict protocol where they should follow follow-up imaging. So depending on the nature of the initial injury, you'll say, great, you're going to get a tertiary scan or a secondary CT scan 48 to 72 hours after the injury, if that type of injury is going to likely cause some sort of intra-abdominal trauma, right? So I think you follow the suspicion on these kids and say, all right, was it a severe accident? Are there any other broken bones? Were there something enough to indicate to us that this was a really severe accident? And if so, I always err on the side of caution and get a CT scan, especially if there is that read from the outside radiologist, because we live in a world where if you miss something, you're in big trouble. And plus, rather than letting the kid declare themselves and get sick under your watch, you might as well just be proactive about it. So to answer your question, I think you err on the side of caution. You rescan 48 to 72 hours afterwards, I think, unless you have some suspicion that, hey, this kid looks sick, there's something not right, the urine shows us something that they didn't check at the outside hospital. They've got a lot of bruising. You just do a good exam and find out, all right, what's the nature of what happened to this kid? And does it set off any alarm bells in my experience?
So in your experience, have you found any benefit or stock in getting ultrasounds instead of a CT, especially in patients who have only microhematuria?
I haven't, but that's not to say it's not valid. I think one of the things that I see very differently is working at the level 1 trauma center without a peds really heavy focus, is that when kids are brought into us, they're really, really sick and they're already coming in with really high grade traumas. And so there's less questioning. It's more just, hey, you're going to get a CT scan. The biggest thing that I will find as the trauma urologist is they didn't get the delayed phase scan like we'd like. So, thinking of a renal injury protocol scan where you get a pre-phase, a contrast phase, and a delayed phase. Well, they forget the delayed phase. And what I think is really, the best thing you can think about if you get this phone call is, hey, how long ago did the kid get scanned? Oh, just 2 hours ago. Put him back through the CT scanner, send him back to the donut of truth. Because if you find out that if they had a urine leak that's significant, if they even have a bleed from their artery or from anywhere in their kidney, you're going to scan them again and you're going to see all that contrast. But at least it gives you an idea right away. But I haven't seen a lot of utility in getting ultrasounds unless it's this case of a kid who really looks stable, had a pretty okay scan at first. Maybe there was some wishy-washy call in the radiology report, and you just want some evidence to say, hey, I don't want to scan this kid again.
That's a good point about the delayed scan. I feel like sometimes if we get lucky and the kid came in recently after his CT scan, instead of giving a full dose of CT as trying to follow the ALARA principle, we might get a KUB, and then if you see a lot of retained contrast around the kidney, you might say, well, that's probably a urine leak and whatnot. And then, of course, if the child goes to the OR for any other intervention and you do not have delayed phases, you might decide to tack on a cyst and retrograde if you can. That's even less radiation than a full CT scan. I don't know, I feel like oftentimes in peds, we like to get a ultrasound, a baseline, not just to address the degree of renal injury, but for follow-up, especially if there's a perirenal hematoma. I've seen several of my partners get an ultrasound while they're in the hospital prior to discharge, so that when they follow up with you in 6 weeks, you can repeat an ultrasound and reassure the family that the perirenal hematoma is improving or whatnot. I don't know if that's a practice that you do in adults, or maybe it's just us in peds using silk gloves, to treat our patients and our family members.
I do think that's it's more of a peds practice, but you point out something really interesting. I teach the residents at our hospital that the IVP, an intravenous pyelogram, is a lost art, right? We always now, if you practice adult urology and you're doing kidney stones, you'll say, well, why don't I just get a low dose stone protocol CT? So nobody gets an IVP anymore. Unless I tell them, if the kid came directly to the operating room and they're already open on the table with general surgery, they don't put them in stirrups. They've got them supine, and you might not even have the correct gear at your hospital, right? Like some hospitals don't have a pediatric scope to be able to check, but it's the perfect time to do an on-table IVP. So I teach the residents that I always forget the dosing, and even in the moment, if it happens, I just call radiology every time because the names of the radiology of the contrast material changes, but you say, hey, what's the dose for a kid who weighs 13 kilos? They tell you. You call for it, you give it to them IV, and while they're on the table, you just call in for the fluoro and you take a couple of shots. And it saves you from having to wonder, okay, is this kid going to have a delayed exposure? And it also prevents you from having to go into the retroperitoneum, explore this kid's abdomen and back further, and potentially come into more bleeding or increasing the risk of needing a nephrectomy. Because if we've learned anything from all of the adult and pediatric renal trauma guidelines over the past 10 years, it's that operating leads to more nephrectomies. Right? So if we can avoid it at all, try to conservatively manage these kids the same way we would for adults too. Really try to avoid it because we want to save nephrons.
That does bring up something that I frequently come across in scenarios like this, the comfort or finding comfort in the discomfort of conservative management. A lot of times we see something really concerning visually on imaging, but we know, right, that at the end of the day, if we're going to be taking this patient to the OR, we're going to end up having to do nephrectomy or, some sort of massive upper tract reconstruction that might leak, and the surgery is going to beget more surgery. And so in your experience, especially, in some of these younger patients, or even I don't know how much, penetrating trauma you see in teenagers. I feel like that's something that you probably run into a decent amount. When it comes to the conservative management of upper tract injuries, what is your threshold to go back and take them for another retrograde or, any sort of diagnostic intervention?
We actually see, sadly, a fair bit. I mean, we had a kid a couple years ago who got shot right through his vena cava and managed to live. It was an amazing story, but it also went right through his renal pelvis and completely just lopped off his ureter at the UPJ. But obviously the kidney at that point is the lowest priority. They were able to save the kid, reconstruct his IVC at the time. And afterwards, you're constantly checking for urine leaks. And we were able to go back. We said, put in a PNT. We'll deal with the kidney later. This wasn't even the time to do a nephrectomy. So got a PNT done. And later on, we went back and actually did a ureterocalycostomy. But directly to your point, I think you're right. Like getting comfortable with looking at an image that looks terrible and saying, trust the data, because it's really big data. It's not like one of these small studies that has 23 patients or 70 patients. These were thousands of cases that they've looked at. And say to yourself, all right, worst case, if I feel really uncomfortable right now, I can put a stent in and I'll see what happens. And give it 3 days, give it 2 days, ask your colleagues in IR to put a drain in. Worst case scenario, you find out that the drain continues to leak. Maybe you need to add a Foley. I almost think of it as like a pressure game in my head. I'm telling myself, all right, how do I reduce the pressure in the kidney for the urine to track the direction I want it to go, right? And if it keeps coming out the drain, if it keeps coming out through the PNT, how do I adjust that? What are my levers that I can pull? How do I lower the bladder pressure? How do I, decompress the bladder? But I think you're right. Get uncomfortable with it and then just trust that, in the end, you're hopefully doing the right thing, for that kidney to save it.
Yeah. I can think of dozens of situations where we've had kids who've had blunt traumas. There's some sort of tear either near the UPJ or, there was an associated upper tract injury with their renal trauma. We put a stent up and then they're, still febrile, like 24, 48 hours later. And we see this also, even in iatrogenic injuries, right? Like whether it's, upper tract recon that we do, a missed injury, we see them have this fever curve and it makes us uncomfortable. You know that there's a little bit of extra, but at the end of the day, like, that there's something leaking no matter what, because the stent is not going to be occlusive. But it's really understanding that balance of letting them ride this out without missing something. And I think especially for Niccolo and myself as people who are kind of earlier in their careers, sitting on our hands and just watching them sometimes can be really uncomfortable. And so in your 9 years of practice, have you seen situations where you've done this, right? Like you've put a stent up, you see a patient having persistent fevers, you put a Foley in, maybe you have to put a perc tube in. In your experience, have you come across scenarios where even that is not sufficient and you still ultimately end up having to go back fairly urgently?
To be honest, no. None of them come to mind. Like really.
That's great.
And I mean it, like I've experienced all the rough, hurdles, road bumps along the way. I've had to tell parents, look, we're trying to preserve this kidney. He might or she might declare to us in 2 days with a fever that they have urine in their back, because that's where it'll want to drain to. And if that happens, we need to put a drain there. We might need to upsize this stent. But I just try to be as transparent with the parents as I can and let them know that, look, there's no crystal clear answer. This is, no two injuries are alike. We have a big picture idea of the roadmap, and we're going to try to follow that. But
yeah, as you mentioned, big data shows that conservative management is key, which doesn't mean no aggressive intervention, but it means endoscopic intervention, IR, our friends that are always working, never tired, putting up drains, percutaneous tubes and whatnot. And I feel like that really helps. Patient is febrile, rescan, fluid collection, add a drain. That's not going to hurt. It is the trip for a child back to an operating room of sorts under anesthesia, because oftentimes in kids you can't do under sedation. But I feel like that even if there's a huge bleed, hemoglobin is dropping, you're transfusing hemodynamically unstable, ask IR to embolize. I feel like that's always the answer. And I mean, the only time in my brief career where between fellowship and attending hood where I actually had to intervene in a renal trauma was a devastating trauma that the patient not survive, where the teenager was like almost severed in half by a seat belt. And I remember like the ureters were flopping in the wind. And even in that case, what we did is like put up stents in the kidneys and the proximal uterus, tie them off, and then come back another day to survive to fight. Now, since we're talking about uterus being disrupted, children's due to their age and their flexibility, they tend to be more prone to UPJ obstruction. So what would you do if they call you and they say, on this CT, we see complete disruption of the UPJ? How would you intervene in that case?
So I think it's always worth trying to stent once. I do think in kids, again, considering that a PNT, well, it also depends on their age. I take that back. Like if someone is so small that I think we don't even have the stent size at our hospital because we don't keep an armament of every size stent, then I'm comfortable with saying, look, we have to get a PNT, we'll delay the repair. But if they're, even older than 7 or 8, especially, I'll say, great, let's take them back and at least try to do a retrograde, because I think CTs don't really give you a really perfect opinion because or a perfect view of the disruption. You can't really tell, I think, the grade of the disruption based on the CT that easily. You see a big blush of contrast coming out the ureter. It doesn't mean if it's a small hole or if the whole thing is ripped in two. So I'm always, one to say, well, let's take it back and try, because I think there's some advantage to aligning those for the future repair that's probably going to be necessary either way, much like with urethral work and SP tubes. And we'll get into that a little bit later. But so I think, I always tend to first try to stent and at least do a retrograde and see, as long as the kid's size appropriate for such an intervention.
At what point do you find that this buys you, I guess not necessarily even buying you time, but aiding you within this current hospital stay during the trauma management, that you'll be taking them back for a definitive repair? Or is this more further down the line?
We usually delay it and send them further down the line, because most of the time if the kid's in a severe enough injury, has a severe enough accident, they have multiple other conditions that they're working with. So we usually let them recover as long as things are functioning well, as long as the PNT's draining, we don't have a huge urine leak that's, ongoing. If it truly is like a shattered renal pelvis, I think we would probably have to make a decision to go in and operate and take the kidney, is my guess. But I haven't ever experienced that. So clearly that's a pretty rare thing. I think with these deceleration injuries, you usually do get a very clean shear, honestly. And so in those sorts of cases, I think you're fine to say, put in a drainage tube through the back, a PNT, come back to it later.
Well, you brought it up, so let's unpack this a little bit with urethral trauma. What are you doing these days? Primary realignment, delayed?
Yeah. Oh my gosh. I can think of no topic that has changed more in the past 3 years, 4 years. I mean, really, with the advent of the Optilume balloon. So, I tell patients this story. I say, I went to one of the busiest fellowships in the country where we would do over 180. I think I did 185 of these cases in 1 year. And I always tell the statistic that the average urologist would do, like 1% would do 10 urethroplasties in their career, right? And so it just, not to brag about it, but I would tell them like, this is a big, you got the right guy for the job here. I'm the right doctor to fix your urethra. And then I tell them that like 3 years ago, I had to do the open repair every single time. But I explained that the Optilume came around and I've seen such amazing success, at least as good as the literature, if not personally, I think in my experience better, that, why would I not offer that? It just seems like the best option. Now, I'm curious because I don't know I don't think there is a pediatric indication. I think that's totally off-label usage. I have not come across this yet with a kid. So I'm very curious to see how you counsel folks. But if it was me, I would tell, if this was just a urethral stricture in the anterior urethra and it wasn't like a complete pelvic fracture urethral disruption injury, which is way more proximal and you don't have anything across this, I would say, look, let's try an Optilume balloon first. And even then, if we had good primary realignment and it wasn't a completely obliterative stricture, if there's even you can see the light of day across that stricture to the other side, I would probably still try to Optilume it, even if it was a posterior urethra injury. Because, for a kid, I'm always thinking about the psychological effect of what I have to do on them, right? And I think I've seen some adults who have some pediatric urology trauma from their lives from like the 80s and 70s and 90s. You see the type of guy walk in who's like had his urethra dilated 30 times. And they're like, or even the woman, it happens actually more than you'd think in our populations too, but they've had dilation after dilation. And then they start to sweat when you just even mention the idea of a cystoscopy. Well, I always think with a kid, if they come in and they've already been through a huge trauma and then now they have to have a catheter for 3 weeks after having surgery, let's minimize that as much as we can. So full disclosure with the parents and saying, look, we don't know what the long-term, implications of using this drug are. It wasn't studied in a kid, but as far as we know, it's pretty safe. Hypothetically, it should be out of the tissues, we'd think, in 6 to 9 months before this kid's going to be child, rearing age or trying to have children or fertility concerns. Then I think try it.
What's the youngest age that you've done an Optilume on after a trauma?
Probably mid-20s. Yeah, but I haven't tried it for a straight pelvic fracture urethral disruption. But mid-20s, somebody who came in with like an impact trauma of like landing on a fence, a straddle injury, and they had the classic type of stricture. I've done it on everybody from in their 20s. I haven't done a true pediatric patient, but in their 20s up to 90 years old.
Yeah.
So
that's interesting. That's interesting because I feel like, apart from the size, oftentimes in peds when we see urethral injury, it's like in the setting of like massive pelvic trauma, just because the pelvic pediatric bones are more flexible. So if you have a trauma that has enough force to shatter a pelvis, usually you're going to get a gnarly injury. In that case, you can try primary alignment. Otherwise, you put an SP tube and come back to find another day. And those are usually gnarly, if not completely obliterate, almost obliterate strictures. So in those cases, very few. And those usually we've been able to do through a perineal approach, kind of like you would do for an EPA, but more aggressive. And in those settings, when you're approaching like a teenager, or even like a prepubertal boy, perineum, and you're dividing that bulbar urethra, the thing that always goes through my mind is like, what are we doing to these child erections in the future? Because you're transecting spongiosum, you're transecting erectile tissue. And if you put it back together in a waterproof way, I know I have long-term data. And this kind of aligns with what we do also for hypospadias, like if you're doing a primary hypospadias that has severe, especially very proximal one, severe chordae, oftentimes we end up doing a corporotomy and putting a patch on. So there's always that thought in the back of my mind. It's like, what are we doing to this child erectile function in the future? But no, I feel like in pediatrics, at least where I practice, we're always very conservative. If you have a child with anterior urethral stricture, which in our world most of the time is iatrogenic, so think like hypospadias complications, like oftentimes we try to dilate. There is some old school urologists that would do a DVIU, which I kind of abhor the idea of like cutting scar tissue. But if we see a child that has like a very long segment of stricture in their urethra, especially anterior, we revert to the ideas like scrap all the scar tissue, put buccal down and do a stage repair, which you're absolutely right. In a 18-month-old, however traumatic it is, it can probably still generate some medical PTSD. But in teenagers, because that's oftentimes when we see these children come to our clinic, that definitely generates a lot of psychological trauma, because for like 6 months, you have to go out with a filleted penis. But the Optilume is interesting. I've not yet encountered any pediatric urologists, and I wonder if it's probably like the size. And just for like, if other pediatric urologists happen to listen to this conversation tonight, what are the size of the Optilume?
I was about to say, so it probably does really limit your choice, because the smallest Optilume I know of is 18 French. So it goes 18, 24, and 30. There's good evidence, or at least anecdotal evidence, I believe, that the bigger size, using a 30 helps more if it's like a bulbar stricture. So, with a pediatric patient, you've really got to be careful. You obviously can't overdilate.
Probably talking more like a post-pubertal trauma, or patient who had some sort of bike accident.
Right.
And so I'm thinking possibly like someone who's in their late teens at potentially. Yeah. Right. But it'd be very interesting to see if this is something that in our world we'll be able to pick up on. Yeah.
I'm curious to go back to the point on diversion and SP tube and delayed repair, because I think I have strong opinions on this one.
Please go ahead.
So I know that there's been data that goes back and forth that says that, well, primary alignment as a first choice is okay. And then basically what I mean is trying to get a catheter across if you can, great. And like in the setting of somebody who has a urethral disruption after a major car wreck, let's just get specific. And then you're supposed to be able to take that catheter out and have them follow up, at unknown times, 6 weeks, 8 weeks, 3 months later, and look to see, did they scar down again? I personally believe if somebody has a true disruption, a PFUD injury, pelvic fracture, urethral disruption, distraction injury, I think a primary SP tube is always the way to go. I think if you can get a catheter across it, I think it does help. I think it can help with realigning the urethra and bringing two ends a little bit closer together to heal. I think you still, in my experience, 100% of the time, you end up with a scar. Even if it's pre-aligned, if it's realigned over a catheter and it heals over scaffolding, I've never seen one of those heal and not stricture down. So people who say, well, no, skip the SP tube, it's more cumbersome, it, makes our orthopedic colleagues angry because they don't want to have an SP tube in the setting of their pelvic hardware. I say, well, all you're doing is you're like adding in a whole nother step to the future final repair. Because if you just do a primary realignment and then you take this out, in my experience, if it's going to fail 100% of the time, you're going to end up with some sort of emergency SP tube because the patient comes back, they can't pee. You have the choice of dilating them again, then putting in the SP tube, waiting another 6 weeks because you need that urethral rest for the scar tissue to declare itself again, which is, again, just more time to have another catheter that you could have completely avoided if you just put it into the first point, taken out the urethral catheter a few weeks after the injury, and then just done a rug or a scope to look, okay, you have a stricture we need to repair. Let's do it next week. It kicks the can down the line in my experience. And I'm curious if in peds you guys feel the same way.
Yeah, I mean, I think so. I would say that obviously the biggest concern that families have, I found that most families have bigger issues with the actual urethral catheter rather than the SP tube, because that is something that's irritating the child more, especially if this is, a prepubertal adolescent child, that's much more bothersome to them than an SP tube alone. I would say a decent number of these patients were able to tape it in a way, kind of tuck it away for them to not, manipulate too much. It doesn't become as much of a bother. But I don't know if that's also been your experience as well, Niccolo.
Yeah, I think SP tubes are like the way to go. Like in peds, we don't see a lot of like traumatic strictures like you do, Travis, but we see a lot of like iatrogenic strictures. And I feel like an SP tube, it's the way to go. It's much easier for them to manage. It also allows urethral rest, which I think all three of us strongly believe in due to our mentor, Dr. Mori. And I still teach my residents here at Baylor about it. And I think the only issue that I do encounter with SP tubes is like sometimes when you leave them a little bit longer than a month, like you have to exchange them, and not every child is willing to undergo a change in clinic. So oftentimes that requires a trip to the OR for a quick sedation and SP tube exchange. But that overall, if sedation helps them avoid PTSD, from medical trauma. I'm all about it.
And from your perspective, Travis, obviously it seems like most of the peds patients that come to your facility tend to be pretty significant traumas. And so when you are doing and you're having your residents do your trauma evaluation in this type of setting, what is your kind of teaching for them, and like what would you want to impart to folks that are, either in a community or this patient's not going to a dedicated pediatric hospital when it comes to a child, so a prepubertal child, and the utility of a rug? The reason I'm bringing this up is because we, especially in the peds world, run into a lot of issues where if we try to get, we usually end up having to, at least I have to do the rug myself, which, I'm fine with because I know exactly what I'm looking for. But if you have radiology try to do it, they end up doing a VCUG inadvertently, or they're not really able to get enough oblique views for us to take a look at it. And so do you find that the rug, when it comes to a prepubertal child, has as much stock and, you get as much information out of it as you would in an adult patient?
You're right, I don't get as much utility out of it. In fact, I don't think I've ordered just a rug on a kid less than 15 years old. Yeah, a prepubertal kid in the last 9 years. I think in my setting, most kids are coming in with such severe trauma that I'm either going to do an on-the-table cysto just automatically. And I say, right, if there was blood at the meatus and the trauma team called me and they're saying the kid's going back to the operating room right now for an X-lap, I'll say, great, I'll come in while they're still asleep. I'll do the cystoscopy right now, get it done under one anesthesia and just be sure. Or if there was really just a questionable history of trauma, they'll even just try to put the catheter in, and they'll only call me if they say that there was difficulty with the Foley. So I don't think, I'm trying to think of a really good reason. I mean, in an acute trauma setting, I just haven't seen much utility in it. And you're right. I think it's the only other thing to do is when you first establish yourself at a hospital, especially if you're going to be a trauma urologist, a pediatric urologist who might deal with this, is find someone in IR or in radiology who has an interest in this. I was so lucky to find a radiology tech who loves body fluoro and does the best rugs, cystograms that I've ever seen. And he just told me right away, he's like, oh yeah, I love doing these. I'm so glad you're here. Like you're like the number one orderer of them. And I'm like, this is great. So, I can always trust the quality of the work, but I mean, just reaching out and finding out if anybody, likes it or does that. And if they do, just try to tell them what you're looking for specifically. I think we don't talk enough sometimes between the departments, and just reaching out and saying like, hey, this would really help me. And they're like, oh, okay, got it. Like, I don't know. I learned about a new thing called like a Russian sizing ball that they put on the fluoro images. I'd done this for all of residency, all of fellowship. I'd never seen this thing. And suddenly I meet the guy at our hospital, and he puts an exact, it's basically like a ball bearing that's perfectly sized, and it allows the radiologist to even measure on an x-ray. Like way more accurately.
Oh, wow.
Yes, little radiopic markers, they put them on perineum.
It's
we
like
use them for cholecograms.
Right.
Yes.
Yeah.
Yes.
And I'd never seen this. I finally asked him, I was like, what's this white ball on every x-ray that you do? He goes, oh, that's the Russian sizing ball something. I'd never even heard this term. And I was like, oh, that's amazing.
Sounds something should be illegal almost.
Yeah. Is that what he calls it specifically, or is that what's officially called?
Exactly.
Questionable.
But I 100% agree with all of you. It's like talking with your IR colleagues or the tech is fundamental, because I feel like, especially in the pediatric world, the tech or the radiologist doesn't really know what a rug is. So whenever you ask for urethral images, they revert to the VCUG. And that's the worst thing that I could do, especially if suspect a stricture, because the Islamic catheter through the stricture, they dilate it, and then the child voids, and you're like, yeah. Or like, is this like this normal pain in urethra? Is it because you dilated it? Or like, yeah. So I feel like the few times where we had to do rugs, more like for like delayed presentations of issues, even like in teenagers, unfortunately, we tend to bring them to the operating room. We do it ourselves. We put the patient on the bed with the wedge, and then we kind of use it as a diagnostic and potentially therapeutic scenario, because if we do find that there's like a significant stricture, we then put an SP tube right there and then. But one scenario that oftentimes get called in the pediatric setting from the ER is the classic little child that either had his penis squished by the toilet seat between the seat and the bowl, or they were like playing and got kicked, and then they come to the ER and there's blood in the urine. In that case, how would you approach that scenario?
That's a good one. I think comparing it and contrasting it to the adult world, right? So we think of penis trauma, we think of a penis fracture right away. And personally, I like an MRI because I've had an ultrasound fail way too many times and underrepresent urethral injuries and really bad tears. We had one of those cases back in fellowship. I don't know if you guys were there or not, but it was, yeah. An ultrasound said there was maybe a questionable tear, and it turned out the whole urethra was ripped in too. I had the exact same thing happen in my practice here. Yeah. So I learned not to really trust ultrasound, at least not really. If I have a really strong question and I'm like, I don't know, like, let's get an MRI. That's if the patient really is averse to getting surgery. If the mechanism of the injury, if the physical exam has a lot of bruising, I think you do the same thing you would with an adult. You say, all right, look, there's really bad bruising here. It could be the urethra, it could just be the corpora, but either way, we're better off dealing with this under anesthesia. And if they're bleeding, if they're peeing blood, I think then you really are, you're more inclined to tell the parents, look, the only place that blood comes from is from a urethral injury. We might be lucky and it might be superficial just from the mucosa on the inside, but it's best to find that out now so we don't end up with a urine leak into a contained space like the scrotum, like the penile shaft, where I think you end up with a lot worse, outcomes. I also think that in those cases, if it's really bad, especially in really tiny kids, if it hits one item, it's going to hit a couple. So you really are, I think, obligated to look for scrotal injuries that could involve the testicles. And if you can get a testicular ultrasound first, fine, if it's not that urgent, just to get some evidence and see. But I think, again, depending on the mechanism of the injury and how much bruising you're seeing and how much pain the kid's in, and if there's blood in the urine, you say to yourself, look, I'm just getting all the factors in my head, all the warning flags saying, go to the operating room,
And by blood in the urine, I'm talking about gross hematuria, not like microscopic hematuria, right? Because I feel like most of the times these toilet seats are like scare the family, exam is completely normal. As you said, the ER always likes edges on the abundance of cautions, ultrasound of the scrotum is normal, and the child is peeing. Microhematuria in those cases are like, well, if he's peeing without any pain, then follow-up is needed. But it's true, it's like bruising and whatnot, because you said MRI is the way to go for adults, especially for penile trauma, and then we can talk more about that. But in children, I always like to remind everybody, MRI, unfortunately, oftentimes requires sedation, unless you're like an adolescent. Just because sitting still in the tunnel with those loud noises can be pretty traumatic, and then you're going to waste MRI time for poor quality images, and then you are back at a starting point we have to explore.
Right. Totally agree.
I think what you said at the very beginning of this podcast applies so much to this specific scenario, is to really get a solid history. There have been so many times where I have gotten called about possible penile injury, possible urethral injury, penile fracture. I've gotten so many penile fracture calls just in my brief career, and none have been penile fractures. And it's because I think like you said, it's a knee jerk, right? Oh, something happened to the penis, it must be fracture. And I think that's kind of carried into what what is readily accessible online, especially for consulting services, for families, for patients. And so, you're a parent in the car, and I say this as a parent, right? Like, I've taken my kid to the ER for stuff. I'm actively Googling things. I'm asking ChatGPT. It's giving me all the worst possible answers. And even though I'm a doctor, I'm still reading this, just panicking. And so you have these families that come in and they're like, oh, I've read online that this happened to my kid. He has a penile fracture. He's not going to, get erections anymore. He's 6 years old. It's something that we run into quite often. And I think one thing that, I have learn to become more comfortable with is kind of what we've been hinting at, which is, really trusting your gut, trusting the patient's history and their assessment before you start with aggressive interventions. Because, I'd be doing a lot of negative penile explorations if I took every penile fracture consult to the operating room. And I think what you highlighted, the combination of the mechanism of injury, right? Like, especially, 6, 7, 8-year-old kids who get kicked in the groin area, unless they have a massive erection during that time, it's highly unlikely, right, that they've fractured their penis. And so really taking the time to take the art of the history is so critical, especially for us in pediatric urology. And you just get so caught up, I think, in an emergency situation that it's really inspiring to hear that as a trauma urologist, that is still such a crucial part of your medical decision making, because we have so much access, right, to MRI, ultrasound, imaging modalities, blood tests that we can get. At the end of the day, if the mechanism doesn't make sense, then putting that child through that intervention may not make sense either. And I think it's really that combination of the mechanism of injury, the actual presentation, and the additional factors that's building a case for you to take that patient to the OR. That's really how I kind of started to reframe my thought process. Is I have to convince myself in a lot of these circumstances that it's worthwhile for that child to go to the OR, rather than let me just do this because I'm just going to do this to, cover all my bases. But then you may end up getting a penile hematoma from the exploration. You may end up, contributing to some sort of injury. There's still risk with that intervention. And I think it's just important to take a step back and really put all of the pieces together. Evaluate the patient yourself, depending on what your support is, right? If you have residents, APPs, what have you, going in and just getting a better sense of what's going on sometimes is the most crucial aspect of this decision making. So yeah, I think, for us, like Nico said, MRI can be a little difficult in these situations. I've actually done a few penile Doppler ultrasounds myself, but it's with the experience of what we had in fellowship, seeing a lot of those penile ultrasounds myself, so I kind of know what I'm looking for. But at the same time, not everyone has those those modalities readily accessible to them. And so, I know you mentioned that you've seen a lot of missed injuries when it comes to penile ultrasounds, but when you are looking at a penile ultrasound, Travis, what do you feel like are the key elements that can be helpful for you, and what things have you found where you're like, okay, you know what, this is not actually giving me a slam dunk answer that there's no injury here, I'm going to get that MRI? Like, have you found in the past 9 years that there's been some things that have made you say, okay, like, we got to step this up with more definitive imaging?
Yeah, I think and this is going to sound negative to my radiology colleagues out there, but when the read is wishy-washy, like whenever the read comes back as like, it looks okay, maybe there's a possible something, I go like, hold on.
Correlate clinically.
Yeah, correlate clinically. Call urology to determine if there was an injury. That's where I'm like, okay, we have two options. We're either going to explore, or if it's 2 a.m, I'll say, hey, maybe if I do have the good fortune of having, the trauma team and the residents from surgery there. And I can say, hey, ask the patient if they want me to come in and take them into the operating room right now. And half the time they'll go like, no, they really don't want any penile surgery right now. It's like, great, let's get an MRI first to be sure. And they'll say, okay, sounds good. So then we can get the MRI, buys us a few more hours, and we can be really certain, A, about the location, and B, about the severity of the injury. Because we really can say with that, yes, there is an injury to the right corpora, and it might involve the urethra. So I think it really helps. But to go back to it, it's like whenever there is like not a very clear normal picture on an ultrasound, something is like setting off a big warning sign. And it might just be that they see this huge hematoma, but you don't get huge hematomas from superficial vein rupture in like the dartos. You only get that from a corporal tear, or from a urethral injury that's maybe not even producing blood in the urine. Maybe it's not full thickness, but it's something that you probably want to go in and actually explore.
Penile trauma, and like true penile trauma in pediatric patients, is either, unfortunately, the ones that we see, it's penetration, so gunshot wounds. Some young teenager acting cool puts a loaded gun in his pocket and unfortunately sets it off. In that case, you automatically buy yourself a trip to the UR. Or you get these teenagers that, they come in and then they're like, yeah, I think I broke my penis like a few days later. And then you start asking them, well, how did it happen? And they're like, well, I was playing video games, had an erection, and then I said wrong, and then I heard it pop. And I feel like you either get those that are not going to tell you the story straight, because teenagers often come to their parents and don't want to disclose they were engaging in sexual activity, or you get the other kind of patients that often see the very nervous teenager that thinks like, oh, I think I broke my penis. And then that's where Arthi was saying, you were saying the history taken, and you're asking, okay, well, did you hear a pop? Did you lose an erection? Were you able to get other erections and stuff like that? So I feel like, if somebody says, yeah, I heard a pop, and then it's like, yeah, I had multiple erections for the past week, in that case, like, well, you're probably fine. It's nothing bad. But oftentimes I've had 2 patients that had true penile fractures, and they were like obviously having sex, but they're not direct with you. And in those cases, huge hematomas, like you said. We went back to the UR, and it's never like, they never come when it happens. It's usually delayed because the parents see them walking funny. It's like, well, what's going there, son? And then it's like horrible operations, no planes, these like day-old hematomas. It's never pleasant.
No, that'd be. I'm actually pretty glad that I don't have to usually go in on those, because when I get them, they're in the acute phase, and I know how bad it is a week later or 3 days later. It just gets substantially worse. So I'm not envious of you there.
That actually was a question that I had for you when you were kind of describing the situation where you have the patient to get the MRI the next morning and then, potentially explore afterwards. What have you found in, the last almost decade in practice? Like, do you really feel like the sun can set on a penile fracture, or the sun can rise? And like, what do you feel like is that time frame?
I think honestly, 48 hours is still okay. It's not, it gets harder like when you get beyond 24 to 36 hours. But almost for the comfort of my partners who weren't reconstructive urologists, who do general urology, they're way more comfortable in every way with waiting and sending it to me. So I think we've kind of established, just by practice patterns and with the nature of our call, to say, hey, this came in at midnight, or if it comes in at midnight, do you think it's okay at 6 a.m. when you come in, or at 7 for the OR? And we'll say, yeah. And then we kind of learn to push it a little bit longer and a little bit longer through practice. And now I think there's even been some papers that I've seen the headlines for that even said, like, how quickly do we need to repair these? And no one's really proving that there's that much worse chance of ED if you wait 2 to 3 days. I don't think that there's that much of a significant change. It gets to be a little bit trickier of an operation, like you said, Niccolo, because the planes get worse. But I think this, if it's like, do you want the person who doesn't do a lot of penile explorations going in at their not best moment, or do you want to have the person who does do a lot of penile explorations do it 12 hours later? I think you're better off choosing that option, or at least somebody who has experience in that area.
And speaking to that, where do you, this kind of applies to most of what we've been talking about. I think that when it comes to peds urology and, adult recon, like we're obviously, we're so interconnected and related, and with everything that we do for the most part. When it comes to collaborating and bringing somebody on board for, some of these reconstructive procedures, where do you see the line for that? So for a penile fracture, do you find that there's just certain cases where it's like absolutely needs to be done together, or this is certainly something that can be done by a peds urologist, or vice versa? Like, in your experience, have you been doing most of these cases together with someone, or does it not even matter?
Yeah, no, I get it. So I think I just keep that mindset of like, hey, on every one of these cases, do I feel like I do enough of this to justify making this kid my first or second? Or, knowing that we have 2 pediatric hospitals right down the street. We don't have a pediatric urologist in-house. So if this is a problem that comes in and I say, we can safely temporize this kid right now, if they're not on the table and it's an emergency, I feel like, if I have to, I'm going to do whatever's necessary. But if this is ever a chance where I'm like, look, I do this all the time in adults, but I've never done this in someone your size, and this kid's in your child's age, that's what I'd want somebody to tell me about my own kids. I want them to be honest and tell me, like, this is not what I do every day. So I'm happy to say, but I know who to tell you to go see in town. And I'm happy to make the phone calls and, really build up that referral pattern to the people that I know and trust in my community and say, hey, I've got a, UPJ obstruction in a kid that we discovered after a trauma, and just going back up to upper reat trauma, and say, I don't have the ability to do a laparoscopic or robotic repair in a kid. I'm not credentialed to do that. Can I send this to you? And if they say absolutely, or if, we'll work out every scenario from they don't have insurance, they can't be seen by us, to, this was a trauma and it had to be done now. I think we've seen about every scenario we can.
Yeah. Collaboration is the key to success.
Yeah, right.
But even beyond the urology world of collaborating, I think, a very common call that we get in pediatric urology that probably not as much for a general adult urologist is, female genital trauma. And so we will frequently get called about vaginal lacs because, we have, 8-year-old little girl who, had a perineal injury. There's concern for a vaginal laceration. The reason why we're getting called about it, in the emergency room is because the patient voided and there was hematuria. But a lot of times it's because of the nature of how they're voiding, when it's not going to be a clean catch, they're not going to get a catheterized specimen, and it's going to show up with blood. And so a lot of times we end up taking a lot of those patients to the OR to scope them and, evaluate their urethras and do a full vaginoscopy. In your experience, especially when it comes to these multi-system traumas, when it comes to children, what has been your role as a trauma urologist when it comes to addressing concurrent vaginal injuries?
It's essentially it's to rule out a fistula or an injury that requires an open repair right away, which would be things like bone fragments, foreign bodies in general, and then fistulous connections. So I think that's where we get involved the most. And so, we'll say, okay, if there's any concern on a CT scan, on a delayed scan, and we have to operate now, we'll go in and we'll say we're going to, work with gynecology. And even though they don't have pediatric gynecology at our hospital either, can work through the trauma workup with the peds surgeons who we do have, who've kind of experienced a bit of everything because they do a lot of peds trauma too. So they're a huge help to be able to rely on. And, we've had wild cases together where, well, it's more bladder trauma, but just stuff that's happened with, like you said, seatbelts. But I think your biggest point of in the immediate trauma setting is to rule out, okay, is there a fistula that I want to try to close right now? A connection, a tear between two cavities in the body that I want to prevent from becoming permanent. That and bones, making sure you don't have bone fragments, because a lot of those injuries that are going to do that, they're really traumatic. And like you said, they'll rip up the pelvis pretty bad.
Now, talking about other traumas, we're leaving out the gonads, testicles. And, oftentimes we see blunt trauma. Texas here, Friday night football is very big. Classic helmet to the scrotum. Kids don't like to wear protection. So you have these kids, and oftentimes they present delayed. Sure, if a child comes in right after a football game, big scroll hematoma, ultrasound shows gonadal injury, testicle injury, you take them to the OR for exploration. But what if the child shows up 3 to 5 days later? What's your take on that?
Yeah, I think you have a couple different options. Again, you'd need to be honest with the parents, tell them that this isn't how it normally should present. You say that we're doing this outside of the normal guidelines. The guidelines are all about what happens in the immediate setting. You have blunt trauma that comes in and, I'm supposed to explore this because the mechanism tells me there could be an injury. It's the classic guideline expansile hematoma, right? Which whoever sits there and watches it, and if anything, you have to sit there and check it every 2 hours and be like, I think it's bigger. Nobody really spends that time, right? In the real world, in the real practice, right. In the real practice, it never happens.
I see you.
So that's it. And so there's a whole lot of charts pictures in the media tab too. It's like, so what we end up doing is saying, and I've had this happen up north, of course, it's a hockey injury, unlike in the South with football. But, they say, I took a puck to the groin, and it, you need to look at it, examine them, really get a good feel. If you feel an intact testicle, and I think feeling the architecture of it's really important, right? Because if you feel like this giant lumpy mass and you're like, I think your testicle's ruptured right now, then I might not say, let's wait, 3 months and see what happens. I might say, there's a pretty nasty case of testicular rupture in here. Let's get in there right now before you lose the testicle to a pressure injury due to a tamponade compartment syndrome style injury. And let's go in and see if we can save it. And then we'd kind of act pretty urgently. I'd say, let's do it today or tomorrow. If they're a little nervous about it in the moment, I think you don't want to put the fear of God into these kids, but you want to say like, look, this could be serious and this could lead to you losing your testicle down the line. So I want to try to save it. So let's operate sooner. That's option number one. But then there's the principle of conservatism and with kids and saying like, okay, look, it's pretty mild. Yeah, you have some bruising. There's a little bit of swelling, but I can still feel a testicle. Let's get an ultrasound today right away, call down to radiology, see if we can get one urgently and take a look to see what it looks like. And if we just see a hematoma, well, if it's 3 days out and it's not an expand-style hematoma, clearly it wasn't because it's not the size of a grapefruit or a softball by that point, right? So then you're probably okay waiting and saying, well, let's follow up and see what happens because you might end up having really chronic pain and you might come to me and say you need to have your testicle removed. This thing might atrophy, but let's follow up in a few weeks and just do some serial checks to check in and see how you're doing.
Yeah, I feel like it's always balancing. I mean, acutely, you can easily justify a trip to the UR. Subacutely, a few days later, I feel like I always talk with them so that we can go to the UR or watch it, especially if there's nothing expanding, if it's something stabilized. I always tell them we can go to UR. As we mentioned earlier, for penile injuries, it's always going to be a more difficult operation, hematoma. So I always kind of warn them, we'll do our best. There's always a small chance that we'll not be able to fix it. You might lose the testicle there and then. Yeah, but I was telling them that's why you got two.
Exactly. I've seen both of these cases happen. And one was in a true peds patient, and it was a hockey injury, and it happened exactly like I said.
Heated rivalry, yeah.
Ooh, I'm not. I know the reference. I'm not that old. I'm not that old guy on the podcast. I know, but I haven't seen it yet. My wife's telling me we're absolutely going to watch it soon, so I know we will. But
I don't know what it says that both of us said that almost at the same time, but it's same
great.
Person.
Oh my God. But I have seen a case where somebody didn't operate and it ends up with this nasty big hematoma that led to chronic pain of the testicle, and it probably just compressed the testicle. So I've seen that happen in real practice. And so I think it's something to worry about. If you have a big enough hematoma that it's causing like ongoing pain even 3 to 5 days later and it's like big, I'd say, you have less of a chance of long-term problems if you go in there, operate, evacuate that horrible chocolate pudding-like hematoma, at 5 days later. And then you give them a scrotum that is then decompressed and a testicle that can heal, then if you just let it ride, I think, in my experience.
A testicle adjacent, my question for you is what has been your experience in managing epididymal injuries, especially traumatic ones? We tend to see a decent amount of these in peds because a lot of these patients can have epididymal cysts or, have really kind of novel injuries. I think beyond just blunt injuries themselves, if they just bump into something, I feel like depending on how much force that can happen or the item itself, a lot of times we end up kind of hearing a little bit more of an unusual story in pediatric urology when it comes to some of these blunt injuries. And so beyond just testicular injuries, a lot of times because, these testicles are certainly smaller, we sometimes see concurrent epididymal injuries. And so I was wondering if that's something that you've seen in your practice and how you've been able to approach them.
Yeah, when you guys messaged me about that, I was like, I've never seen, I think, an isolated epididymal injury aside from, I believe, maybe one gunshot wound that was just like a somehow direct shot that took out an epididymis, but somehow the testicle still had blood flow and it was alive and well. And so I did an epididymectomy in the moment because, penetrating trauma, you're like, okay, I'm going in. But with a blunt epididymal injury is interesting. I don't think I've ever seen that in practice.
Oh, interesting. Okay.
Yeah. So do they present, I'm curious about this. Do they present like with an enlargement weeks later, or is it in the moment and they get like a swelling in the moment? Okay.
I've seen one teenager, basketball, got hit.
I had two, yeah.
And it's kind of acute, like they're painful, right?
Mm-hmm.
Yeah.
I mean, they present just like a blunt scrotal injury, but of my two, one of them came in as, a 7-year-old child who allegedly ran into a dresser. And then another one fell off the back of their couch. But it was a pretty low couch and then presented that way. And so the reason why I said it that way is a lot of times we may not necessarily get the actual injury itself. And so a lot of times I've just wondered if it's something about the pediatric testicle epididymis complex that is contributing to this, or if this is just Nico and I happen to attract this because we've talked about this ourselves, just the two of us, and between the two of us, we've actually had this conversation, more than once, clearly, just about an isolated epididymal blunt injury. And both times, I watched it conservatively because, I felt the risk of intervening and trying to do an epidydymectomy was going to be greater injury to the testicle itself. And at the end of the day, this was most likely going to render some sort of obstructive process for this child as they go into adulthood if they, had any interest in child rearing. And so both patients are fine and, haven't heard from them since in a positive way. But, it is sort of an interesting nuance, I think, for us in pediatric urology that we can sometimes see some of these types of things that, I just find it fascinating that this is something you haven't even come across.
Yeah, that is amazing. I mean, I think you guys see a little bit more epididymal like swelling and inflammation, I think, in pediatric already. And I just thinking about how that would like pathophysiologically work. I wonder, but like,
the one that I saw was weird, teenager and trauma pain, but the way that the epididymis expanded, there was not really a lot of reactive hydrocele. It felt like a hard mass. And like my differential was like, this is probably testicular rhabdomyosarcoma. And the funny thing is on ultrasound, I was like hyperhemic, and then, but like the mechanism was weird. There was trauma involved. And, like we always thought, like usually when teenagers or young adults diagnose themselves with testicular cancer, they try to remember if they had a trauma, kind of like to explain the sudden increase in testicular size. But the story was very weird because like the parents were like, yeah, there was nothing the days before, basketball game, got hit. And in that case, it's like, I told them we can go and explore, but then if I would explore in that case, since it could be malignancy, we have to do an inguinal incision, deliver the testicle, and most likely just take out the testicle versus wait. And we waited like a couple of weeks that in the big scheme of things, even if it were rhabdomyosarcoma, it wouldn't really change prognosis. And it turned out that it became avascular. And then it became non-tender anymore. And then over the course of a few weeks, it started to become smaller and smaller. And then after, 2 months, 3 months of conservative follow-up, it turned out to be just a big epididymal hematoma. But it was very bizarre. Just epididymis, no testicular involvement, no hydrocele from being elbowed playing basketball. I don't know.
I think that's really important to highlight to people is like the value of a 1-week follow-up. You know what I mean? Like it's overlooked and we always like feel like we're so stressed and like I'm booked out for months to get into clinic. It takes forever. But just remember that like seeing somebody back in a week does so many things. Like it hits the emotional part for the patient to feel like they're really being cared for. They feel like you're invested in it. They know how busy you are because they know it was hard to get into your clinic anyway. And now they're like, wow, I'm going to squeeze you in next week. I want to see you. I want to check on this. Let's make sure this is getting better. And I think as a doctor, again, making sure that you did it all right the first time and you actually, paid attention, you can learn a lot about what happens in a week, and the cases in which you're going to lose a lot of ground are really slim. There's only a few. So I think that's really smart.
I think it also just helps you as the clinician, and especially for, Nico and myself and, other people who are earlier in their career, trainees, listening to this, it helps you get closure as well and helps you get resolution because, I can't tell you how many times I texted Niccolo, I had a patient like this and I'm wondering if they're going to be okay. And we talk about this all the time that, a lot of times some of these short-term follow-ups are to also heal us in this process as well and to become better clinicians because the more reps we get in of seeing things, the better doctors we become. And I think especially as urologists, because so much of what we do involves long-term follow-up. I mean, I know we're talking about trauma and talking about a lot of acute processes here, but we have not we clearly have not even scratched the surface, right? We could have a whole other session about the long-term management of every single one of these anecdotes that we brought up. And the vast majority of these patients require more than just, one quick check-in someday. Like some of these patients need long-term follow-up because of the body system that was involved. And I have found that doing some of these, I know we were joking about like Q1 hour scrotal checks, but, some of these frequent inpatient assessments, some of these shorter term outpatient follow-ups has given me such a great window in how to counsel the next time I've gotten called about some of these issues. And so it's very helpful to hear that as a trauma urologist, that the outpatient and kind of the follow through of this is so critical in learning more about how to manage these patients later on someday as well.
Well, I think we're getting towards the end of our time, and let's conclude on a fun note. Weirdest foreign object you had to extract from a bladder. That's not a bone fragment.
Oh yeah, no. I have a whole wall of weird that I've collected items, and this was adult, so it wasn't pediatric. It doesn't count for you guys as much, but 2 feet of 12 gauge electrical wire.
Okay. What about
you, Arthi? That's like a Romex cable that goes in your wall. It was huge.
What about the kid?
A Jedi lightsaber. Yeah.
Full size or like miniature Lego?
Like the 14-inch action figure size. So it was a pretty sizable one. Okay. The other one was a baby carrot. That was an adult too, though. But that one's always a hit. Yeah.
But a baby carrot. So.
But a baby carrot. Just a little.
Yeah, not an adult carrot. It was a Pete's carrot.
What about you, Arthi?
I think a crochet needle.
Oh.
Or crochet hook. Yeah.
Now, the worst one I've seen, buckyballs.
Yes.
Because they tend to turn into a little ring in the bladder, and then you have to try and like separate the magnetic spheres. And then after a lot of raging, you end up doing a cystotomy. It's like, ugh.
Well, and those could be really concerned. I mean, like our ped surgery colleagues talk about this all the time, right? Like those not Orbeez, those metal balls, the magnet ones that can, perf bowel. I mean, that could have been a real situation if that patient also ate it. As we're wrapping up, Travis, certainly like one of our goals in doing this podcast was to not just shed light on what we do in pediatric urology, but to help us as pediatric urologists, understand where we can continue to learn and adapt and evolve our practices and set the patients that we see up for success as they go into adulthood, so that, if they do need an adult urologist, it's for hopefully something that does not have a significant quality of life impact on them. And so I have to say, I've learned a ton in the past hour. But, my question to you is, what do you find to be kind of the most helpful piece of advice that you gained in your own practice over the last 9 years when it comes to addressing traumas? And what do you want to impart to the community of pediatric urologists listening in on us right now?
Ooh, that's a big question. I think a couple things, like life lessons that I've picked up on and been taught that I've carried forward. First, in like the transition between peds and adults, I think y'all probably already know, but finding somebody in your community who likes reconstructive work is huge. And just maintaining a good relationship with them so that when, let's say somebody becomes 18 years old and you're like, this isn't really in my practice pattern anymore. Who should I, really talk to, or can I talk to? You could, if you like it, you can be the pediatric urologist that carries people till they're in their 20s. It's fine too, right? But if you want to just focus and work in one specific age group, I'd say find a good relationship with people who have, either neurogenic bladder practices, who do reconstruction like me, who just have a special interest in adult urology and have a really caring personality. Find that out in your community. And then I think the other one, and this is true for everybody, but whether it's trauma, whether it is your own practice, but take your most difficult cases and your problems and hold them closer, right? Don't walk away, don't step back from a complicated case. Because when you do that, you're not only hurting yourself, but you're also, leaving the patient feeling alone and upset, right? bring them closer. If you have a success, say, great, see you in 10 years, right? If you have an awesome case that went perfect, you don't need to keep a stable full of patients like that. As you get into practice and you start to operate a whole lot and you really encounter complications and challenges and things that, you may have thought you did everything perfectly, but it didn't go right for the patient because the human body is not a car and you're not changing oil. That's going to happen. Embrace it, pull them in closer and try to let them understand it and work through it with you. That's my best piece of advice, because I think you will have a more successful, happier long-term career if you do that.
That's extremely well said. I feel like the more you're at sea, the more you're bound to get wet, and even the greatest surges of complications, being able to embrace them, disclose them with even other physicians makes you a better surgeon. I never trust doctors that have no complications. I mean, there are very talented surgeons that have very few complications through years of experiences and perfecting their skills, but zero complication. The only way to get zero complication is if you don't operate.
And you still can't, right? Like, they could still be leaking from that gunshot wound. That's still going to be a complication.
That's true.
You still may, no matter what you do, you're going to get complications, because this is what Dr. Moore used to always say, this is a contact sport. And so you just got to keep going. And I think trusting your training, and this is what my mentors always said, trust your training, trust your gut, and continue to have compassion for the patient. It's pretty difficult, I think, at that point to deviate to the point of no return. And it's so amazing to see that 9 years of doing urotrauma and working incredibly hard as you have been has not changed that level of compassion that you had, for as long as we've known you. So it's great to see that, as you've evolved, that part has stayed the same, and if anything has just continued to grow. So it's been really incredible to see what you've done up in Minneapolis.
Well, you guys, it couldn't be happier to talk to you guys tonight. It's great. You're some of the best residents I ever worked with. So it's a real honor and privilege. Thank you, guys.
The honor's all ours.
Thank you, sir.
Thanks so much. Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.